So the first of the cyanotic heart diseases that we'll discuss is transposition of the great arteries. So what are the great arteries, you're probably wondering? The great arteries are considered the aorta and the pulmonary artery, and they're both derived from the truncus arteriosus. And we're going to talk about a transposition of the great arteries, meaning that they switch places. So you'll see that the aorta is actually derived on the right, and the pulmonary artery is derived on the left in transposition. And the one that's important for us is the dextro-TGA, which means that the aorta is found on the right of the pulmonary artery. And this is the only one you need to know for USMLE purposes. And the problem here is an abnormality of the aorticopulmonary septum. You're probably wondering, what is this aorticopulmonary septum? We're going to go all the way back to embryology for this one. So the aorticopulmonary septum is derived from the neural crest, migrates over to the heart, and is super important for division of the heart, the septums of the heart between the atria and ventricles, and also for the valve formations, and also for division of the truncus arteriosus into the aorta and pulmonary artery. So, have you ever heard of the term endocardial cushions? The aorticopulmonary septum is one of the endocardial cushions, and all of those cushions are derived from the neural crest. So, another thing is that the aorticopulmonary septum is found to twist on itself, and that's what forms the normal anatomy we see in our bodies. So let's talk about this for a second. On the right, we have our pulmonary artery normally in all of us, okay? And on the left, we have the aorta in all of us. And the way it looks in our bodies is not just going up and going up for both of them. They actually twist around each other. So we'll start with the pulmonary artery starting here. What it does, it first goes forward, then it goes to the left, and then it forms its divisions to supply the lung and come back to the left atrium. The aorta, on the other hand, starts on the left, but then it moves to the right, and then forms a loop, which is the aortic arch, and then comes back down as the descending aorta. So you see how these two twist on each other. This is very important for the normal anatomy we see in our bodies. But when you have transmission of the great arteries, this kind of twisting never takes place, and that's why the aorta is on the right and the pulmonary artery is on the left. So take a look at what happens as a result of this condition. It's pretty bad over here. So we have the right atrium and right ventricle with the aorta attached to the right side, left atrium, left ventricle with the pulmonary artery attached. And there's no shunts that are mixing these two sides together. So as a result, blood is just going in a cycle to the lungs and back to the left atrium, with oxygenated blood never reaching the body. And we also have deoxygenated blood going to the body and coming back in a cycle without ever reaching the lungs to get oxygenated. So as you can tell, this probably is not compatible with life. You need to have some kind of mixing of this blood to give oxygen to the body. But now the question is, how does the baby survive? Why is the baby not dying in utero? How can it be born? And the reason why is that in the baby, in the fetus, you actually don't use the lungs for oxygenation. You use the placenta of the mother. And the placenta of the mother will supply the body and the right atrium and all of the whole system with oxygen, and the lungs are shut down. So as a result, a fetus will not be affected by this condition until it takes its first breath and depends on the lungs, and the PDA closes. We'll talk about the PDA and its importance a little bit later, but this is why the baby does not die in fetal life. So the aorta now is abnormally found to the right and anterior to the pulmonary artery and arises from the right ventricle. So you can see how abnormal this is. Normally it's to the left and posterior of the pulmonary artery, and now it's to the right and comes from the right ventricle. So this is all very abnormal. You also have the pulmonary artery now abnormally found to the left and posterior to the aorta, which we now know is abnormal, and arises from the left ventricle. So these are all very strange, and this is why the transmission of the great artery is such an important condition and can cause so many problems. Key concept: can an infant survive this defect without an additional congenital abnormality? No, we just saw here that if there's no congenital abnormality mixing the blood together, the baby is just going to die because there's no way for the blood to mix. So that's why you need to have some kind of mixing. And the mixing will be caused as a result of a PFO, a VSD, or even a PDA, which is not shown here. But all of these different shunts are going to allow for mixing the blood between the right and left circulations. And as a result, you can get some mildly oxygenated blood reaching the body instead of completely deoxygenated blood reaching the body. One thing I want to clarify is that this blood is not 100% deoxygenated. It just has less oxygen than is sufficient to supply the body. And this has a little more than the light blue, but still is not adequate to supply the body, and that's why you get cyanosis, because this blood reaches the body and is venous blood partially. You notice that the lungs are able to oxygenate the blood, and then this blood mixes and allows for some oxygen to go towards the body. So that's a very important thing you should know about this. So you require pain foramen valve, VSD, or PDA for survival. So what's the result of these two abnormalities? Massive cyanosis, because you're not getting oxygenated blood to the circulation properly. So now a critical thinking exercise. Which side of the heart pumps against greater pressure, in a normal heart or a TGA heart? In a normal heart, the left side pumps against greater pressure because the left side has the aorta coming off of it. So it'll be much bigger and stronger and be able to handle those pressures. But in transmission of the great arteries, the right ventricle is the one receiving all the blood flow that goes to the systemic circulation, and it's pumping against the aortic pressure and the systemic pressures, causing the right ventricle to be very likely to fail and very likely to overload because it's not supposed to be handling these kind of pressures in these kinds of environments. So very important to know is the right ventricle is very highly likely to fail because it's not supposed to be handling these kind of high pressures. Now let's talk about signs and symptoms of transposition of the great arteries. So the first symptom we want to know about is cyanosis shortly after birth. So this should be pretty understandable. We talked about in the previous picture how deoxygenated and hypooxygenated blood is reaching circulation, and that's going to cause cyanosis. Metabolic acidosis as well. How does that happen? Tissue hypoxia. If you have tissue hypoxia, you get anaerobic metabolism, lactic acid production, and metabolic acidosis. You also get heart failure in the first few weeks of life, and we discussed this as well. The right side of the heart is pumping against increased pressures and is overloaded and cannot handle these kind of high pressures and volumes and ends up failing. So the large ASD, VSD, and PDA that are required for life, they also cause problems because they add more blood to the right ventricle and put greater volumes and pressures on it to support the body's needs. And that's why the right ventricle is very likely to fail and also be very large on chest x-ray and also show right ventricular findings on EKG. The RV cannot keep up with the metabolic demands of the body due to the partially oxygenated blood. And that's why it's going to be pumping harder and faster because it wants to try to keep up with the needs of the body, but it can never reach that because the oxygen is not in high enough quantities in the blood. So tachypnea results, tachycardia results, and dyspnea results, and all these are features of the right ventricle trying to keep up and meet the body's demands. We have a single loud S2 heart sound. Why is that? So the reason why is that the right ventricle is providing blood supply to the systemic circulation as we discussed, and the systemic circulation is much higher pressure and resistance than the pulmonary system. So remember, in order to open a valve, the right ventricle needs to pump and have enough pressure to open up the valve. So let's talk about this in a diagram actually. Let me show you a little bit of on a pen. So say we have the right ventricle here, okay, and we have the aorta. Aorta has very high pressure, right? And we have a valve between them. The right ventricle needs to meet that pressure and exceed it to open this valve, and then that's going to allow blood to go through. And the high pressures that are needed to overcome this valve opening are not going to be transferred to the aorta, and that's going to move backwards and snap the valve shut. And that's going to cause a loud sound on the aortic right side, which means a loud A2 on the right side because it's high pressure and volume. But on the other side, you have the left ventricle, and you have the pulmonary artery. Pulmonary artery doesn't have as high pressures, so the pressure is going to be kind of lower. So the left ventricle doesn't need to have as high pressure to open the valve, and the pressure that's moved to the pulmonary artery will exert a smaller force against the valve and cause a very soft sound. That's why you get a single loud S2 heart sound. Very important to know. Alright, so now diagnosis. The ways to diagnose is first an EKG. Right ventricular hypertrophy is going to be found because we've talked about how it's going to fail because there's too much pressure and volume inside of it. And right axis deviation because the right heart is so large. And remember when you do diagnoses, especially in cyanotic heart disease, these infants are in very severe condition. So the first thing you want to do in any situation is stabilize the patient, correct the vitals, give fluids if needed, give oxygen to correct the hypoxemia. And then you can start doing other things such as EKGs and chest x-rays to manage the patients. So chest x-ray is going to show an egg on a string appearance, and we'll talk about what that means. Egg on a string, classic terminology when it comes to the transposition here. So when the right ventricle gets so large because of the volume and pressure, it pushes the left ventricle to the side and creates this form of egg shape. All right? And you notice that the mediastinum doesn't have a lot of vessels around it when it normally does in our chests and on chests of infants that are normal. So what happens here is that the aorta is coming off of the right side and just forming the aortic arch right behind the mediastinum and the sternum, instead of looping around and making the wide traversion. And the pulmonary artery just goes straight up and back and supplies the lungs. So that's why the mediastinum and the center of the sternum does not show a lot of vasculature, and it looks like it's on a string. So that's the egg on a string appearance. So you have an enlarged right ventricle and aorta on the right of the pulmonary artery. Echocardiogram, as always, is the best test, And you're going to do that after the EKG and the chest x-ray to definitively diagnose this condition, and then surgery will be the treatment afterward. So now for some treatment options. First thing you need to do is you need to open up the patent ductus arteriosus and keep it open, because it closes around 24 to 48 hours of birth. And if you close the PDA, you're going to have a greatly decreased blood supply to the right side of the heart, which is supplying the systemic circulation. You need the PDA to be open to allow for blood supply to be possible. So why is this important? It maintains the PDA, allowing for mixing of oxygenated and deoxygenated blood. Remember, the shunts allow for mixing so oxygen can reach the body. It also increases pulmonary blood flow. Remember, the aorta has higher pressure than the pulmonary artery. Blood's going to go left to right into the lungs, increase the left atrial pressure when it comes back by the pulmonary veins, and that increased left atrial pressure will move the blood back into the right side with more oxygen so it can be pumped to the body. An issue can arise if the LA pressure is very high, and that may close the patent foraminal valve. And we'll talk about that later, about how the patent foraminal valve is due to more pressure on the right than on the left. And if you have more pressure on the left, it will close the patent foraminal valve. And finally, you have intubation and mechanical ventilation as a resort if necessary, if the patient is completely crashing, and surgery for definitive management.